And good afternoon, everybody. It's my pleasure to moderate this panel. The purpose of disability programs, generally speaking, is to support people who are unable to work, retain a certain quality of life. But in order to do that, the programs have to be accessible and work within and with a broad system of other supports and services. The common theme in these papers, in this panel, and the broader research in general, is that not everybody eligible for social programs like SSI, DI, SNAP, and other programs actually makes use of them. While there's been a lot of research into the reasons for the three papers in this panel add new information to this discussion. Mike Levere of Haverford College, Mathematica, will present research on the take-up of SSI by children and how it relates to area measures of deprivation, helping answer the question of where there could be underutilization of SSI. Carly Urban of Montana State University will present findings that help us understand the role of mental health serviceability and DI and SSI take-up. And finally, Amelia Hawkins from Brandeis University will present findings on how the cash-out option for food stamps affected SSI recipients' food stamp use. I won't take up more time introducing the papers, though, so let's get right to it. Mike Levere, the floor is yours. Thanks.
All right. So, can you see the screen now? Great. So I am sorry. As Jeff mentioned, I'm going to talk about the relationship between deprivation and child SSI participation, and this is joint work with Dave Wittenberg at Mathematica and Jeff Hemeter at the Social Security Administration. And the standard disclaimer applies here that all opinions are our own. So very quickly, just deprivation is an economic measure that sort of captures the level of economic, kind of a lack of economic well-being, reflects employment, poverty, as well as a number of other factors. And so the question that we posed in the title was, what's the relationship between deprivation and child SSI participation? And the relationship is strong and positive. On average, there's a really high correlation, so that as economic deprivation increases, so does participation in child SSI. But that overall masks some substantial variation in this relationship across geographic areas. So there are plenty of places that, and the places we're going to be particularly interested in this paper are those that have high levels of economic deprivation, but low levels of SSI participation. And these are places that offer an opportunity for outreach to potentially ensure equal access to the program and ensure that places that might most be able to benefit from SSI are aware of the program. So the goal of this paper is going to be first to document that geographic variation in the relationship between deprivation and SSI participation. And then we're going to look into some of the potential drivers that can explain this mismatch. So we'll look at some characteristics of local areas, such as, that might explain why is there high deprivation but low SSI participation. And we're going to look at this at the census tract level. And so this is giving us the opportunity to have a lot of variation, as well as have really precisely targeted outreach in very localized areas. And finally, another thing that we're going to do is assess how the relationship kind of affected recent program dynamics during the pandemic. So all of our primary analyses are conducted before the pandemic. So we're looking at child SSI participation in 2019. But as you just heard on the last panel, the pandemic has affected things, and there's been a big drop in participation. And so, we're going to look at this in a little more detail. There was room for improvement in kind of outreach before the pandemic, but the declines in SSI participation may have exacerbated some of these existing differences. So very quickly, just about SSI, it's a critical component of the safety net. And for youth with disabilities, in order to qualify, children have to both have a disability, as well as there has to be limited income and assets for the family. And that's related to a parent's income. And this is important because what we think is that this level of economic deprivation is going to be related to SSI because that captures some of this, this means test and a lack of economic well-being. And SSI benefits offer cash payments and health insurance coverage to families of eligible youth. And these benefits can be really important, particularly for families that have a low income, in order to free up time to potentially help manage the additional needs that their child with disabilities has. So a little more detail on economic deprivation. This is going to reflect an area's income and poverty, as well as the employment, education, housing, and a variety of other factors. And this is a really important measure because it gets at this idea that income often isn't sufficient to just fully capture a family's needs. It's not like a holistic measure that captures overall well-being. And so we're going to use a measure of economic deprivation that was developed in a couple of papers. And this was these papers so basically the measure of economic deprivation is coming from data from the American Community Survey. And again, we're going to calculate this both at the census tract as well as at the county level. And the census tract, just as a little bit of background, it's a very narrow geographic region that typically includes about, on average, 4,000 people. So these are very narrow, precisely defined areas, and I'll show you a little bit more what that looks like later. And this measure of economic deprivation was developed in these papers along with to kind of rank neighborhoods by their socioeconomic disadvantage relative to peers. And so the goal was then to inform health delivery and make these potential interventions and policies more effective. And so these papers by Singh and Kind et al. Look at things like understanding trends in obesity and diabetes, looking at readmission to hospitals and so forth. And so, as I mentioned, given the means test associated with SSI participation, we think that there's going to be a correlation that as economic deprivation increases, so will SSI participation. And in this graph, that's exactly what we find. So on average, as the level of economic deprivation goes up, so do the number of youth SSI recipients who are participating in, so do the number of youth SSI participants. And it's a fairly linear progression with some slight, even bigger increases at the upper end of this deprivation distribution. But that's what's true on average, but overall, but then there's deviation between predicted and actual participation. And that's what we're going to be really interested in, is finding these areas of mismatch. So we estimate a simple linear regression between deprivation and child SSI participation using, there's 74,000 census tracts. And as you can probably guess from the last slide, that relationship is strong, positive, and highly significant. But then what we do is, using the level of deprivation, we're going to predict the level of child SSI participation that might otherwise be expected only based on the level of deprivation. And then we calculate this deviation as the difference between the actual and the predicted SSI participation. And so a negative value here is going to mean that actual participation is less than the predicted participation. And this deviation is basically just a residual from that regression. So this map shows you the US, and this is at the county level. And it shows, so the red areas are those where actual participation is less than predicted participation. So these are areas with negative deviation. And then the green areas are those with positive deviation, where actual participation is greater. And what we see is that the areas with actual participation being lower than predicted are primarily concentrated in the Midwest, while those that are higher, where actual participation is higher, are concentrated in the South and in the Northeast. But critical is that there is a lot of geographic variation. And so this is at the county level, but what I'm going to show you on this next slide is a map zooming in with the census tract data just on Detroit. And so you could do this in any variety of metropolitan areas, but we chose Detroit because it's an easy map to look at. And what you can see is that there are a lot of census tracts here that, even within the city of Detroit, there are those kind of pockets that have actual participation lower than predicted. And there's some other pockets that have actual participation higher than otherwise might be predicted. And so that speaks to this potential to maybe, as in conducting outreach, be able to really hone in on very narrow specific areas. It's not that we need to go to Detroit as a whole, but we can even focus in on very particular areas within Detroit where participation might be low. And here's just another example looking at Lancaster, Pennsylvania, just showing, again, there can be a lot of variation, even just within a kind of a local metropolitan statistical area. So the next thing that we do is we look at the local factors that are correlated with this measure of deviation. And so we ran one regression where our outcome variable is the level of deviation, and then we look at how a bunch of factors that I'm showing you, all these characteristics in these rows here, are associated with that level of deviation. So this is one regression that's weighted by population. And what we find is that first and foremost, the thing that stands out the most and that's the strongest predictor is the percentage of the population that is non-white. So as the percentage of the population is non-white increases, so does the measure of deviation. So another way to think about that is that the larger is the share of people who are white in a local area, the lower is actual SSI participation relative to what otherwise might be predicted based on the level of deprivation. This isn't terribly surprising given that we know communities like that people who are Black and people of color tend to have higher rates of SSI participation. We also see that as the percentage of the population with a disability goes up, so does that measure of deviation, showing that kind of more people with disabilities are likely to participate in youth SSI. And then the one that I especially want to highlight here is this level of social capital. We're only able to estimate that. That's a measure that we only have at the county level, but we show that areas that have higher social capital have greater deviation. So that places that have lower participation in civic, religious, and sports organizations also don't seem to participate in SSI and youth SSI to the extent that would otherwise be expected based on the level of deprivation. And finally, looking at these regions, it's similar to the pattern that I showed you in that map earlier. So youth SSI applications during the pandemic. In 2020, youth SSI applications declined by 17%. We're not going to get into kind of why that happened. There's a lot of potential reasons, and we hope to be able to speak more about that in a future paper. But what we find relative to this study is that counties that had a higher level of deprivation, economic deprivation, had slightly larger declines in SSI applications. And similarly, we also saw that counties that had lower levels of deviation had smaller declines in SSI applications, but these areas with low deviation already had fairly low applications. So to some extent, both of these findings speak to the fact that areas with low applications, it can't really go lower. So to wrap up, we find that deprivation is related to youth SSI participation, but some local areas have high deprivation, but have low SSI. And with these maps, we can really drill down in very narrow regions to try to understand participation. These deviation measures could be an effective tool for policymakers to consider in conducting outreach, and we're planning to make that a data set available with this estimate of deviation. And one thing that I just want to point out quickly is that SSA has been making efforts to improve access to services for particularly vulnerable populations. So they've created this new position called a vulnerable population liaison that's going to go to work with organizations and local communities. And I think that this measure of deviation and some of our research here can inform the way that these new kind of positions and people can potentially be deployed and to really focus on these areas where outreach might be most effective in improving take-up of youth SSI. So thank you very much. I appreciate it.
Thank you, Mike. Let's turn over to Carly now, please. Thanks.
Everybody can see that screen? Awesome. Great, so thank you so much for having me. I'm excited to talk about this. This is joint work with Isaac Swenson here at Montana State. And what we're really looking at is access to mental health services and how those relate to SSI, SSDI applications, and then awards. And then just like everyone else has, we have the disclaimer, all of our own work and words. So as a lot of you may know, mental illness in the US has a high prevalence. So over 46 million adults suffer from some form of mental illness, and about 5% of all adults have a serious mental illness or SMI. Those burdens are really concentrated among those with SMI, and those with severe mental illness are the ones who frequently rely upon government disability benefits to survive. So in this paper, what we're trying to understand is how increased access to mental health services affects federal disability program participation. And in particular, we're looking at that initial application decision. Others have studied mental health before and how that affects the labor market in particular. So mental illness is one of the leading causes of sickness absence and incapacity in most high-income countries. And there are effective treatments, but treatment rates remain very low across the board. In the context of SSI and DI, there's actually limited evidence that suggests that mental health interventions can reduce dependence, but a lot of that is looking at kind of a continued reliance on the programs versus those initial applications. So we're looking at that beginning side and not at persistence in the program. So what we're trying to do is put some numbers on that causal link between mental health services and disability program participation. Okay, so despite there being expansions over the last decade plus, treatment rates remain low. And the biggest barrier that is cited is the inability to locate a provider. Even when folks do or are able to locate a provider, wait times at outpatient clinics can be weeks or months. So there's this long time delay, and longer wait times have been shown in previous research to lead to favorable outcome or less favorable outcomes, right? The longer you wait, the less favorable the outcome may be. So what happens when you reduce these barriers? That's what we're asking. What happens when you actually have more access? Does that change participation? Now, this could go two ways. It could be that after you reduce those barriers, people now have access to treatment and they are doing better. They're able to stay in the labor market. Or it could go the opposite direction. It could mean that you get access and then you have an appropriate diagnosis. And after that, you are able to apply for SSI and DI. So what we're going to do is we're going to use data from the County Business Patterns, the CBP, and we're looking really at the number of establishments or single physical locations by county and year. We also look at employment in these establishments, but I'm not going to show you that today. We really look at office-based mental health care providers. So again, thinking about a brick and mortar establishment, and we're using their NAICS codes, following other literature to really signal two different types of providers. The first is offices that have physicians and mental health specialists, and the other is offices without physicians. So I'll talk a little bit more about why that might be important later. But this again is very similar variation that's leveraged in previous work to study things of the nature of how these establishments affect mortality or dependence or things like that. Okay, so what does it look like over our time period of study, which is 2010 to 2016? The darker colors are going to show the bigger expansions and the lighter colors are going to show contractions. So across many CBSAs across the country, we are seeing large expansions in mental health facilities, so these office-based mental health facilities. But there are some places that either stayed the same or declined over the same period. So we're going to be using that variation to really understand how that affects SSI and SSDI applications. So first, we get these county level data from SSA directly, thank you. We have county by year applications and awards. We're limiting this to the prime age population, so 18 to 65 from 2010 to 2016, matching our CBP data. They do censor all the county year observations with less than 10. So to make things kind of simple and clear so we don't really have to screen based on that, we're going to keep the counties that have a CBSA code since they're a little bit larger in population. The counties will all be a micropolitan area or larger, and we're going to replace any additional censored cells with 5. It's similar with previous literature, and we'll show you some robustness checks without that. Okay, so again, leveraging this change in establishments within counties over time. So taking care of cross-county comparisons, we're going to include year fixed effects, so we're going to take out differences over time. And we're really looking at how these expansions are affecting take up of mental health services by basically relaxing these capacity constraints. So it could be that, again, these services might introduce new options or lower cost options to the community. And then what happens when you have more access? Okay, so I'm going to show you all these results in pictures. So first, I'm going to show you SSI Applications. And the first in all of these is going to be the base model, and then all of these are robustness checks. The one to kind of keep in mind is the green, because in all of our models, we are going to kind of adjust for weight by population. So the bigger counties are going to have a bigger weight. So in that green one, we're not doing that. So that's kind of our, if we're just counting every county as one observation, that's almost like what you would think of as maybe more heavily weighting rural areas. So on average, we are seeing that when more mental health establishments open up, there are more SSI applications at the county level, and it's pretty robust across our specifications. See the same thing with DI applications going up, again, across the board, a little bit of a bigger effect if we don't wait. And then we see a murkier effect, slight increase, but not robust when we look at awards. And I'll talk more about that in a little bit, but on average, kind of a questionable 0, maybe an increase. So for those of you who like tables, there are our main results of our baseline model in a table. And to kind of put it into words in a very simple way, what we're finding is a 10% increase in the number of facilities within a county increases SSI applications by about 0.097 or 1.2%. So 10% more facilities, 1.2 more SSI applications. That's pretty sizable, in my opinion. For DI, again, the big difference between SSI and DI being DI, you need some work history. So even for that slightly different population, we are still seeing an increase. So more access to mental health services. A 10% increase results in a 0.7% increase in DI applications. Again, quite sizable in my opinion. And then we see this imprecise increase in SSI awards, but you can think about that as like a 0.5% increase if we did take that coefficient at face value. Okay, now here's the other thing that I think is really interesting. If we break out those types of establishments into those with physicians and those without, the effect is entirely coming from those with physicians. So this is just awards. So those awards, those applications went up, but the awards are only successful if you have facilities that have physicians. So they seem to be the ones getting the appropriate diagnosis that gets these individuals who are applying over the threshold to getting the award eventually. And then finally, although I think I've now been convinced that we should be splitting the sample based on economic deprivation and not a bunch of these other things, we look at high versus low poverty counties and high low education counties. And what we're seeing is this is predominantly coming from lower SES counties. These are all just kind of proxies for SES. Which now we may change. But yeah, we're really seeing that all of these effects, including awards, are really concentrated among the counties that we may expect have more demand for SSI and DI. Okay, so just a quick recap. This is preliminary evidence that really shows expanded access to mental health services leads to increases in participation. So again, a 10% increase in establishments leads to about 76 more SSI applications, 60 more DI applications, and 10 more awards in the average county. Again, the larger effects in those with lower SES, and it seems like physicians are really an important part of this. So excited to talk more about this in Q&A. And I think I actually left a minute or two to spare, so.
Thanks, yeah, you're good. So Amelia, are you ready?
I'm pulling it up. Okay. Can you see this and hear me? Is this working? Jeff?
You're good.
Yeah, okay.
Yeah, sorry.
I'm sorry. Okay, thank you. Let me just make it so I can see it. Okay. Hi, thank you so much. I'm Amelia Hawkins, and the title of this project is Cash vs. Food. How does food stamp eligibility affect the family security of SSI recipients? And this is work with Marianne Bittler, Lucy Schmidt, and Hillary Seligman. The usual disclaimers apply. Okay, to start us off, I need to introduce you a little bit to the institutional background in our context here. As many or most of you must know, Supplemental Security Income Program payments began in 1974. What you may not know is that the federal SSI program replaced state-run programs for the elderly, the blind, and folks with disabilities. And for the most part, beneficiaries on those older state-run programs would have been eligible for the food stamps program. Now, when the federal SSI program came in 1974, states had a choice to make. So they could choose to make their SSI recipients eligible for food stamps, or they could choose to make their SSI recipients ineligible for food stamps, but instead cash out that food stamp benefit. Now, what do I mean by cash out the food stamp benefit? What that would mean is that the SSI recipients would get an additional $10 in their state supplementation program payments. And at the same time, that SSI recipient or recipients would be excluded from the food stamp eligibility unit of their household. So there could have been other household members who were not on SSI who would have still been eligible and might have received food stamps, but the SSI recipient would have been excluded from the food stamp unit. All right, so there were 5 states that initially chose this cash out option, and they have all since ended it. Those states are California, Nevada, New York, Massachusetts, and Wisconsin. And all 5 of these states had more generous benefit levels under the older state-run programs than under the new federal SSI program in 1974. The rules and policy around this are a little bit complicated, but essentially what this meant was that all 5 states could take advantage of a hold harmless provision, which meant that they didn't pay in entirety for the cash out payments. So in this project, we are going to be studying the cash out policy as it started and ended across states and over time. So why are we interested in studying this cash out policy? Well, our motivation is threefold. So first, there is an active debate in the literature whether recipients view income transfers like the SSI program payments in the same way that they view food benefits. Second, we know from the previous literature that the elderly and folks with disabilities have a higher rate of food insecurity, and so this decision to cash out food stamps or not for them might have really mattered. And finally, as far as we are aware, there has not been so much research into the state's decision to cash out food stamps for SSI recipients and its potential effects. So that's what we're going to be doing in this project. We are going to be studying the cash out policy and its effects on food stamp participation, food and economic security, as well as health outcomes for SSI recipients. And we're going to be getting at this project using a lot of different data sources. So I have 2 sets of results to show to you today. The first set comes from studying the start of the SSI and cash out policies in 1974, using the survey of low income, aged, and disabled. And second, I have some results studying the end of the cash out policy across states over time, using the food stamp quality control data, which is a food stamp administrative data set. We also have some data analyses in progress, and we're actually just waiting to get the data in. We are going to be studying how the end of the cash out policy in Wisconsin affected health outcomes for SSI recipients using hospitalization data. We will also be studying the end of the cash out policy in June of 2019 in California, using a wide range of linked California administrative data. In addition, we are conducting interviews with CalFresh, which is the name of the Food Stamp for SNAP program in California, administrators on asking them about their outreach and enrollment efforts to enroll these new SSI population into the CalFresh program. All right. So I just mentioned we have 2 sets of results for you today. So the first set is looking at the start of the cash out program in 1974, using the survey of low income, aged, and disabled, or the SLIAD. And this survey data set surveyed folks who were on those older state-run programs before the federal SSI program came in, and then again in 1974 when SSI came in. And all of the tables I'll be showing you today present differences in differences estimates. So for the slide results here, we're going to be looking at beneficiaries in cash out states versus non-cash out states before and after the start of SSI and the cash out program. The first thing we establish in the slide data is that with the beginning of SSI and the cash out program, we see a large drop in cash out states in 74 in food stamp participation among beneficiaries. This is a 40 percentage point drop. It almost entirely wipes out food stamp participation in cash out states among SSI recipients. What we find looking at another survey question is that this is likely not voluntary. So in cash out states in 1974, 50% of SSI recipients said that they weren't participating in the food stamp program because they had been on it but had gotten kicked off, suggesting that had the cash out policy not come into place, a lot of those folks would have been receiving, participating in the food stamp program. The next set of things we look at here in the slide is food security and self-reported health. So we have two food security measures. The first is asking, did you get enough to eat, which we code as 1 if folks say some of the time or never. And the next is, did you eat the right types of food, which we code as 1 if people say most of the time or always. And then we also look at whether they report self-reported health is poor. Across the first 4 columns here in the difference in differences estimates, we see that the cash out policy led to a decrease in food security. We see that there was a 4 percentage point increase in folks, SSI recipients reporting they did not have enough to eat with the cash out policy. This represents about a 50% increase in reporting yes to that question. The next 2 columns suggest a 5 percentage point decline in folks, SSI recipients within the cash out policy came in reporting they didn't eat the right types of food, which represents about a 6% decline in that question. And the last 2 columns suggest that the cash out policy also led SSI recipients to say they were in worse or poor health, though not statistically significant. The next set of results we have for you from the slide are looking at economic security questions. So we have 2 questions we can get at this here. One is a question asking how often do you worry about your financial situation, which we have coded as 1, our indicator, if they say frequently. The second is how would you describe your ability to get along on your current income, which we code as 1 if they say they can't make ends meet. Okay. Looking at the differences and differences here across all 4 columns, we see evidence that the cash out policy led to a decrease in economic security as well. In the first 2 columns is a statistically significant increase of the SSI recipients saying that they worried about their finances frequently. The second set of results that we have for you today is looking at the end of the cash out policy across states over time, using the food stamp quality control data from 1975 to 1996. This is food stamp administrative data. We have 2 versions of a food stamp take-up rate. I don't have time to go into how we created these. The reason we have 2 and they're different is because there is inconsistencies in the data availability of in the quality control data over time. We'll also show you how the average food stamp benefit in SSI households changed with the end of cash out in Wisconsin. So this is looking at the end of the cash out policy across the 4 states that we can study the end in the quality control data. Across all 4 columns, we see as cash out ended an increase in the food stamp take-up rate of SSI recipients. Because we see a similar increase across multiple states in different time periods, we take this as suggestive evidence this was due to the cash out policy itself. And finally, this is looking at the effects of ending the cash out policy in Wisconsin in 1992. The first column here is the food stamp household take-up rate. Again, we see a similar increase in food stamp take-up rates in Wisconsin after the food stamp program, or after the cash out program ended in 1992. In the second column, we actually see a decrease in the average food stamp benefits reported in households with SSI recipients who were in the quality control data. We believe that this change or decrease in the average food stamp benefits in the quality control data comes for two reasons. One, there was a change in the composition of SSI households entering the food stamp program after cash out ended in Wisconsin. The second is that households that were on the food stamp program before cash out ended that had SSI recipients, but some non-SSI recipients faced a different benefit formula when cash out ended. Before I wrap up, I just wanted to give you a sense of the initial themes coming out of our interviews with CalFresh administrators, asking them about the outreach and enrollment of SSI recipients into CalFresh. So some have told us that some SSI recipients are disappointed by the low CalFresh benefits they find they're eligible for. Some have said that the change in benefits rules and calculations have been complicated and challenging to explain. They have noted that staff training and refresher training has been really important for their outreach and enrollment. And some of the counties have told us that a strong relationship with their local SSA field offices have been really important for their outreach and enrollment of the SSI population into the CalFresh. So just to conclude, what I have showed you today is that we have finding evidence the cash out decision of states really mattered for SSI recipients. We find that when the cash out and SSI program started in 1974, there was a large drop in the food stamp participation rates of SSI recipients. We also find suggestive evidence that food security and economic security decreased at the same time. When we look at the end of the cash out policy and the quality control data, we see that as the cash out policy ended, food stamp take-up rates increased. When we look at the cash out policy in Wisconsin, we see though that the average food stamp benefit amount that SSI households received fell. And our next steps are just waiting on this data. So we hope to have new analyses for you soon, looking at the end of the cash out policy in Wisconsin and in California. Thank you.
Thank you, Amelia. And thank you all for your great presentations. We do have a couple questions in the Q&A, but I would like to take the moderator's prerogative and ask the first one to Carly. So SSA does have some kind of demonstrations in this space. You know, there was the mental health treatment study that looked at providing mental health services to existing beneficiaries. There's the current supported employment demonstration, which looks at providing similar services to denied applicants, as well as relatively a few things for the homeless that seems to be relevant here. That seems to be consistent with some of the findings you've had, that a diagnosis really makes a difference in having access to that service. I was wondering if you could comment on how your findings relate to some of those demonstrations, if you're aware of them.
Yeah, I think exactly how you just said, right? So I think the transition off has been kind of had a lot of results that suggest that mental health doesn't do anything, is kind of like the way people have interpreted it, I think improperly. But I think in my review of kind of the research you're discussing and the research we've done now, is that the access seems to be getting the people who really need the service, right, need the benefits into the benefits, right? And that's kind of step one, is getting some household security to, you know, help, as you said when you kind of introduced the panel, the health and like sense of livelihood of these individuals, right? Getting them up to a level where they're actually like, you know, able to live, right? It's kind of like a really low bar. And then we can start thinking about more other interventions that might make sense for getting them slowly back to work, and like what that even looks like. But I think before we can sort the right people into the program, we need to figure out who those people are. Like, and I think the outreach to like the homeless, for example, who have wide prevalence of severe mental illness is a great population to start with, and very consistent with what you're finding. So yeah, especially with the physician finding we have, like that diagnosis seems to just be everything.
Thanks. So Mike, there were a couple questions for your paper in here about the measure of economic deprivation. I was wondering if you could just explain a little bit more about, how that's measured and what it means to be positive and positively correlated with it.
Yeah. So the deprivation is a measure of, a variety of factors. So it includes things like income and poverty. It includes things like, I want to say it's like, what percentage of the households in the census tract or in the county or the census block group like have a telephone, or there's things like the median house prices. There's a variety of factors in there that go beyond just the standard level of kind of poverty, income, and so forth that directly lead to correspond to the SSI means test. There's then, in terms of the correlation, what we're looking at is we then correlate that measure of economic deprivation with youth SSI participation, and then dig a little deeper into where there are deviations from kind of based on that level of deprivation and the regression, we can predict what do we think SSI participation would be, and then see if there's a gap between the actual and predicted. Does that answer your question?
Well, I kind of know what you did, so whether or not it answered everybody else's question is a little different. So the next question, I want to make sure everybody gets some questions. So for Amelia, so can you say a little bit more about the $10 and whether or not that changed over time, and also what drove some states to make the change away? There were some questions about that.
Yeah, sure. So the $10 was the same over the whole time period. So so even in 2019, when California ended their cash out policy, it was still the same $10 it was in 1974. That wasn't, as far as we could tell, pegged to anything, cost of living or inflation or anything. And why did they end? So the reasons varied a little bit state by state, but essentially what happened was that states kind of ran up against sort of administrative rules and changes to the rules, so for example, Nevada and New York ended their program because they didn't qualify for the hold harmless payments anymore in 1976, and so they decided to end the program. And Massachusetts and Wisconsin, there was a change in their being able to be a cash out status state, so long as they passed along a cost of living adjustment to SSP recipients, and they both ended being a cash out status state right sort of soon after that rule went into place. And in California, my sense is that this has been a change that policymakers and advocates have been thinking about for a long time. And as far as we could tell from talking to those folks in California, the exact timing of this in June of 2019 was a little bit sudden, and they weren't actually expecting it. They had been talking about it for a long time, and then all of a sudden it changed. So we would, that's kind of the best I have for now, why each state ended, without taking up too much more of the time.
Okay. Was there a sense that participants would benefit more from traditional food stamps versus the cash out benefits?
Among the folks we talked to at the California Department of Social Services, yes, I think that was kind of the idea, that this $10 had just stayed $10 for so long, and it wasn't going to be as much as I thought people were eligible for. It's what has ended up happening is that the SSI recipients who are newly eligible for CalFresh in California, they're actually eligible for like a wide range of benefits, and because of the way this works, where the SSI recipient gets added back into the food stamp eligibility unit when cash out ends, the whole household's food stamp benefit level could have gone up or down. And so this was part of, there's actually kind of a bigger change in what benefits people might have been eligible for than I think some people were expecting.
Thanks. So Naomi Fink asked, the dialogue between panelists about how to measure household welfare is interesting. Could the deprivation measure be repurposed for income in retirement, where income replacement is very popular among practitioners in measuring welfare in retirement? Social Security is extremely progressive, but there may still be people in deprivation, even if they have high income replacement from Social Security. Interested in perspectives from the panel. So I will turn that over. Maybe Mike, you want to take that first?
Sure. I mean, this is maybe not the most fulfilling answer. I mean, I think that there's more than just income. And I think that that's important to capture. And this speaks to another one of the questions that we got that I thought was really good about trying to try to disentangle, like how many of these instances are places where kind of it's a high level of deprivation, but that doesn't actually correspond to people being picked up by the means test, versus areas that are, and so there might not be as many people who are eligible versus high levels of deprivation. And a lot of people are eligible, but they're not taking it up anyway. And so it's like people who are eligible but not taking it up, and trying to distinguish that in the context of our paper. And that's, I think, a really good point, and something that we should think a little more about in terms of the original question. Yeah, I think that there's more to it, and I think that these measures of deprivation, they're a little, one of the disadvantages that they offer, they're more challenging to calculate, and so they're not as readily available like the second that the data are out. And if you could see, to have very quick responses of like income and this sort of measure, but I think they do offer a more holistic sense of like the extent to which an area faces economic challenges.
Carly or Amelia, would you like to chime in on that?
I guess I'll make a little pitch. I think it would be interesting to see your regressions thinking about a measure on the right-hand side that thinks about mental health in some way. And I know there's a lot more data on like who is calling into emergency hotlines or things like that you could get at a very refined locality, kind of like and aggregate to a census tract. But I think that might kind of be an interesting other way to think about like access and mental health in correspondence with eligibility and deprivation in some ways.
Yeah, that's a really good point. I'll connect with you later about that, because I think that's a really good idea and good thought that we should explore.
Amelia, I don't know if you have anything you want to say on that.
Oh, no, I think this whole conversation has made me think more about how we interpret those economic security questions in the SIA data, and sort of what is it that they're capturing, because those are questions that I haven't seen necessarily as frequently in other data sets. And I think it'd be worth thinking about what other measures like these ones that you all have put together that our survey questions are correlated or not correlated with. So, yeah.
Great. Carly, you had a couple questions in there. I know you answered them in the Q&A, but I wanted to see if you could maybe say a little bit more about the measures of the establishment data that you're using, and what's going on with consolidation or the decisions to open up the places, these types of facilities, and if you know anything about that, it could help understand why places are choosing to open up mental health centers. Is it a chicken or egg kind of situation?
Yeah, that's a great question. One great thing about this research question is that other people have looked at mental health establishments before us and spent a lot of time documenting that it's actually quite random. So that definitely helps us, especially within counties. Consolidation is something we've thought about from the beginning, where it could be that there are just more providers within one specific building versus like another actual brick and mortar establishment, or vice versa. You can think about that kind of in two ways. One is that if there are fewer buildings, then there is less access for people who live on like the other side of the city or something like that. So that is changing access. But we also have used measures of employment instead of establishments. So the number of office-based mental health employees, and our results remain pretty similar. So I don't think consolidation is really a huge factor, or local access to an extent is not what we're picking up. It's the bottleneck. It's the actually being able to get into a provider. So I guess I'm less concerned about that than anything else. And in our final paper, when it's submitted in like a month or so, we do a lot to establish causality, that this isn't a chicken and egg problem. We do a lot of event studies where we have a sample of counties where there's only one time when openings happen, one event, and we can see clearly that nothing is happening with SSI applications, DI applications, awards before that, and it's really after. And it kind of ticks up like you would expect. Awards take a little bit longer than applications do. So we do see that relationship pretty clearly. It does limit our sample. It's not everyone, but it is quite good evidence that it's not something kind of funny going on.
Great. And one follow-up question from Laura Robinson. What are your takeaways from your data about what kind of information mental health professionals may need to be successful in supporting SSI participation?
Yeah, I think that's something I would love more qualitative work on. I mean, I'm an economist. I'm willing to say I take the 1,000-foot view and say this is what's happening. It does seem like physicians are really important. So even if there's just some physician time, that seems to be moving the needle more. Or it seems like I was just talking to someone in the Q&A where there's a program they're working on with you in California, and really trying to like get providers involved and support those folks who have SMI, these severe mental illnesses, through that application process. So even just some physician time in that process for people who clearly have severe mental illness seems to be kind of like the important factor. But I think for more like what works on the ground, we need to hear from the program leaders, from those who are successful.
Great, thanks. Amelia, can you say a little bit more about why you think the average food stamp benefit fell in your study?
Yeah, thanks. So what we have in the quality control data is the average food stamp benefit for households where we see an SSI recipients in the data sets. That means that we're only seeing folks if they have, if they're in the quality control data, so if they have food stamp benefits. And I think two things are happening. One is the composition of SSI households who are entering the food stamp program, and therefore the quality control data when cash out ends in Wisconsin are households that have really low or relatively low food stamp benefit amounts, so that's bringing down the average. These tend to be households where everyone in the household is on SSI, so they're usually one or two person households, and they just are eligible for much lower food stamp benefits than the households that have a mix of SSI and non-SSI folks. The second thing that's going on is for households that have some SSI recipients and some non-SSI recipients. When cash out ends, as I alluded to before, the SSI recipients then get added back into the food stamp eligibility unit, and their eligibility for food stamps and the benefit amount is redetermined. And so the food stamp benefit that the household receives could have gone up or down, and we see some evidence that the benefit amounts for the folks in Wisconsin at the time were such that the benefits were going to go down. So we are still doing some analysis to try to decompose these two effects, the change in the composition of the households, SSI households and food stamps, from the change in the benefits. So yeah.
Great, thanks. So one more question. So all of the papers use data kind of prior to COVID, at least for the main results. So, as a result of COVID, I mean, SSA and other agencies have made a number of changes. We've heard the last, I think there was a discussion in the last panel about, some of the, SSA field offices are by appointment only, limited access. Other programs have gone more teleservices and the like. I was just wondering, the increased reliance on virtual services and program waivers. How do you think those types of changes will kind of relate to your results, or what is going on? And then think about, Carly in particular, telemedicine and things like that. Is that something that you think will make a difference here or help, but also for everybody else, like what changes do you think your results have or might be different now than they were with the period of your study?
I think for us, the results would be different in the short run and the long run. So in the short run, if everything was, shut down, there was no access basically to brick and mortar mental health services for a short amount of time during the lockdown, right? And probably limited moving to telehealth, I would expect people would be less diagnosed, right? In the short run, at least, who were coming in for the first time or would have been coming in around the first time. Less access to treatment might have meant fewer applications, but then we also saw there was an 1,000% increase in calls to emergency mental health hotlines during the COVID period. So to the extent that there is some additional severe mental illness that we do see in the longer run, I think, we may see expansions in access. We may see that some of that telehealth is going to get really targeted to these folks who, need the benefits and, are having some type of issue where they can't work. So we might actually see in the longer run this increase in applications if these mental illnesses continue or progress. So I think that it might be different from what we're seeing right now in the data compared to what we might see in a year in the data.
I could see with our study things sort of going in multiple directions. So I think on the one hand, areas that have high levels of economic deprivation are presumably those that have low access to the internet. And given that a lot of, I think with SSI it's a little different, but like applications for these programs were done primarily online. If field offices were closed, if people don't have access to the internet, they're not going to be able to apply to the same extent. But on the other hand, more specifically with youth SSI participation, all of the kind of payments that were discussed in the last session and like the stimulus payments that people got, those could affect more generally overall levels of like assets and such. And so because of this really low asset limit that's required with SSI, if you get a $1,500 check and the asset limit is $2,000, you're pretty close right then if you don't spend it. And so, that could in turn be a potential explanation for why applications went down and could affect that relationship as well, particularly in these areas of high deprivation.
Oh, Amelia, you get the last word, I think.
Okay, no, I think I would, our results are gonna be affected the same way as both Mike and Carly have said, differences in short run and long run, as well as differences in who ends up, for example, in California, coming on to the CalFresh program. The other thing I think just in our setting that will be different is the capacity of the CalFresh offices to respond, not just the characteristics of the SSI recipients, but sort of which of the CalFresh offices kind of got faster out of the gate before COVID hit and which have more capacity to keep an outreach and enrollment going through the COVID period is gonna affect the results we get there. So.
Great, thank you. And I can see Michael's on, so we are getting the hook. So thank you all three of you for great papers, great presentations and discussion.